Welcome to Day 6 of the CPC Exam Prep Series by KS Medical Coding Academy. Today, we're starting an important section, Evaluation and Management, or EM coding. We'll cover the basics of what EM is, its structure in the CPT manual, and the key code categories every CPC student must know. EM stands for Evaluation and Management. These codes represent the time, decision-making, and effort a provider puts into assessing a patient's condition. EM coding applies when physicians or qualified healthcare professionals evaluate a patient and develop a management plan, whether in person or via telehealth. EM coding is extremely important for the CPC exam. It's one of the most tested areas. That's why it's located right at the front of the Captain Manual. Mastering this section can give you a major advantage on exam day. When choosing an EM code, ask these 4 key questions. Is the patient new or established? What is the setting, office, hospital, or home? What is the complexity of medical decision-making? If applicable, how much time did the provider spend? Here's a quick refresher. A new patient is one who hasn't received any face-to-face services from the provider or group practice of the same specialty in the past 3 years. An established patient has been seen within that time frame. EM codes are divided into several categories based on the place of service and the type of care provided. The main ones include office or outpatient services, hospital inpatient and observation care, emergency department services, nursing facility and home services, consultations, preventive medicine, and prolonged services. Each category has its own structure, rules, and code ranges. Here are some of the most frequently used code ranges: 99,202 to 99,205 office or outpatient visits for new patients, 99,211 to 99,215 office visits for established patients, 99,281 to 99,285 emergency department services, 99,221 to 99,239 hospital care, 99,381 to 99,397 preventive medicine services. Make sure you're familiar with these. They're commonly seen on the CPC exam. In 2025, the EM coding guidelines for office and outpatient visits were significantly updated. Now, code selection is based only on medical decision-making (OR), total time spent with the patient. History and exam are no longer scored, but they must be medically appropriate. Remember, medical necessity still drives everything. Here are a few common mistakes to avoid. Cross-mark confusing new and established patient definitions. Cross-mark using history or exam to select EM levels for office visits after 2021. Cross-mark skipping place of service rules. Cross-mark overcoding based on time without supporting documentation. Knowing these pitfalls can help you avoid losing points. Let's recap today's lesson. EM codes represent the cognitive work of providers. They're chosen based on patient type, place of service, MDM, and time. Categories like office, hospital, and ED services are essential to master. Don't forget the 2025 updates, especially for office visits. Book for homework. Review the headings of each EM category in your Captain Manual. Write down 5 EM categories and their code ranges. Match 3 real-life scenarios to the correct EM category and code range. Thanks for tuning in to Day 6. Tomorrow, we'll go deeper into EM coding levels and medical decision-making, so don't miss it. See you in Day 7. Welcome back to Day 7 of our CPC Exam 2025 study plan. Today, we're diving into a very important part of EM coding, medical decision-making, or MDM. Understanding how to select the right EM level using MDM is key for success in the exam, and in real-world coding too. In this lesson, we'll cover the different levels of EM services, how MDM works under the 2025 guidelines, and how to determine the correct MDM level using the 3 key elements. We'll also go through real-life scenarios and give you some CPC exam tips. EM services are divided into levels 1 to 5, based on the complexity of the visit. For office and outpatient services under the 2025 CPT guidelines, you can use either time or MDM to select the level. In other settings like the emergency room or hospital, traditional MDM is still used. MDM stands for medical decision making. It reflects the complexity of a provider's thought process during the visit, like diagnosing, ordering tests, interpreting data, and assessing risks involved in treatment. So, MDM helps determine how involved the provider's decisions were. According to the 2025 CPT guidelines, MDM is based on three elements: the number and complexity of problems addressed, the amount and complexity of data reviewed or ordered, the risk of complications or morbidity from patient management. To assign an MDM level, at least two of these three elements must meet the criteria for that level. Let's look at the 4 MDM levels and what they involve. Straightforward. 1. Self-limited problem, minimal data, minimal risk. Low. 2 minor issues or 1 stable chronic condition, limited data, low risk. Moderate. 1 or more chronic illnesses with mild exacerbation, or an acute illness with systemic symptoms, multiple data points reviewed, and prescription drug management. High. Serious problems like acute or chronic conditions with severe exacerbation, extensive data reviewed, and high-risk management like hospitalization or emergency surgery. Again, remember, 2 out of 3 elements must meet the level criteria. Let's look at an example. A patient with type 2 diabetes presents with increased blood glucose. The provider orders lab tests and adjusts the medication. Here's the MDM breakdown. Problem: 1 chronic illness with exacerbation. Data: labs ordered. Risk: prescription drug management. Since 2 or more elements meet the moderate level, this visit qualifies for moderate MDM. Now, another case. A patient comes in with chest pain. The provider orders an ECG, interprets it, and refers the patient for hospital admission. This scenario involves a high-risk acute problem, data review through ECG interpretation, and a high-risk decision, hospitalization. That clearly supports a high MDM level. Keep in mind, in hospital, emergency, or nursing facility settings, the traditional MDM framework still applies. You'll often refer to the table of risk in the Captain Book, which outlines low, moderate, and high-risk situations. Make sure to bookmark that page in your Captain Manual for quick reference during the exam. A quick pro tip: highlight or bookmark the 2025 million German marks table and the table of risk in your Captain Book. Also, practice identifying keywords in scenarios like prescription drug management or acute illness with systemic symptoms to quickly assess MDM level. For the CPC exam, focus on office, outpatient scenarios and understand how to evaluate the 3 MDM elements. Look for signs of data reviewed, tests ordered, or any medication changes. These usually help you determine the level fast. Let's recap. EM levels are based on complexity. MDM has 3 elements: problems, data, and risk. You must meet 2 out of 3 to assign the level, and always use the 2025 guidelines when coding office visits. For your Day 7 homework, try 3 mock case studies. Use your CPT 2025 book to identify the correct MDM level. And tomorrow, we'll move to Day 8, time-based EM coding, another scoring method you need to master. Thank you for watching Day 7. Welcome to Day 8 of the CPC Exam 2025 study plan. Today we'll learn how to use time-based EM coding as per the latest 2025 CPT guidelines. This method is especially useful for office and outpatient services, and it's often tested in your CPC exam. In this session, you'll understand when to use time instead of medical decision-making, what qualifies as billable time under 2025 guidelines, the exact time ranges for EM codes, and how to assign codes based on time alone. We'll also go through a few examples and quick exam tips. Remember, for office and outpatient visits, you have 2 valid options to choose your EM level: medical decision-making, which we covered in Day 7, or total time, which we'll learn today. You only need to use one method, whichever results in the most accurate level. So when should you use time? Time-based EM coding is great when the provider spends most of the visit counseling or coordinating care, the patient has multiple complex issues, or when MDM documentation is unclear or borderline. Just make sure the provider documents the total time clearly. According to the 2025 CPT guidelines, time includes all time spent by the provider on the same date of service, not just face-to-face time. This includes reviewing patient records before the visit, performing the exam, counseling the patient or family, documenting the visit, coordinating with other providers. But remember, staff time and time spent on unrelated services does not count. Here's the official time chart for office visits in 2025. 99,202 is for 15 to 29 minutes. 99,203 is for 30 to 44 minutes. 99,204 is for 45 to 59 minutes. 99,205 is for 60 to 74 minutes. For established patients, 99,212 equals 10 to 19 minutes. 99,213 equals 20 to 29 minutes. 99,214 equals 30 to 39 minutes. 99,215 equals 40 to 54 minutes. These time ranges are essential to memorize or bookmark in your Captain book. Let's look at a real example. A provider spends 25 minutes with an established patient, mostly for follow-up and counseling. According to the time chart, this fits the range for code 99213, which is 20 to 29 minutes. Another example. A new patient presents with multiple chronic issues. The provider documents 68 minutes spent, including review, counseling, and follow-up coordination. That falls under code 99205, which is for 60 to 74 minutes. Here are a few important tips. Always write total time spent, X minutes, in documentation. Mention key activities like reviewing labs, counseling, or coordination. Do not round up, use actual minutes. Follow the exact time thresholds from the Captain code list. Here's a simple comparison. Time-based coding focuses on minutes spent, while MDM-based coding focuses on complexity and decision-making. Use time when the visit is dominated by counseling or coordination, and MDM when it's about diagnosis, testing, and treatment complexity. Also note, time-based coding may get audited, so documentation must be strong. For the CPC exam, watch for phrases like, majority of time was spent counseling. Look for total time documented. If the question gives time but no MDM info, then select the EM level based on time. Also, be aware of add-on codes like +99417 for prolonged services. To wrap up, use total time on the day of service to assign EM codes. Match that time with the correct Captain range. Document time activities properly. Use time-based coding when it provides a clearer picture than MDM. Today's homework. Try 3 practice questions that give total visit time. Match each with the correct EM code using the 2025 chart. Then compare your answers to what you would select using MDM. This will help you understand which method is more appropriate for each case. Thank you for joining Day 8 of the CPC Exam Prep Series. If this video helped you, don't forget to like, share, and subscribe to KS Medical Coding Academy. Tomorrow we'll go deeper into real-world EM case scenarios for both office and hospital settings. See you on Day 9.